Today I wanted to talk about disorders of water and sodium balance. We've had quite a few severe hyponatremias in kids recently. So I thought it would be a good idea to just go through a lot of the principles more than the technical detail, just to try and make sure we all have a good understanding in how this happens. Because I think there's also often some misconceptions about what makes water and sodium go away. Just an outline, we'll go through the importance of sodium regulation, the body fluid compartments, sodium balance, and then the imbalances. So firstly, water imbalance, and then just sodium imbalance. So sodium is the major cation in the extracellular fluid compartment, and it plays a major role in determining the cell volume and maintenance of the ECF volume through the maintenance of the osmotic pressure in these compartments. And it's actively absorbed by the intestines and then excreted by the kidneys and the skin. So plasma sodium is actually regulated by water intake and excretion, not really changes in sodium balance. So when there's hyponatremia, it's usually due to the intake of water that can't actually be excreted. And when there's hypernatremia, it's usually due to the loss of water that's not been adequately replaced. So our total body water is made up of the extracellular fluid, which is usually about a third of it, and then intracellular fluid, about 2/3. And in the extracellular fluid, the major ions are sodium, chloride, and bicarb. And extracellular fluid is mostly potassium, and then the macromolecular organic phosphates. And the relative size of the compartments varies with age. So the ECF is increased in infants and younger children compared with older patients. And the cell membranes between the compartments, so the cell membranes are freely permeable to water. So water can move freely across, and then it's the ions and the concentration, the tonicity, which we'll discuss in a bit, that affects where the water moves to. So the sensors that mediate the extracellular fluid volume are found in the renal afferent glomerular arterioles, which then stimulate the release of renin and the activation of the RAS system. And then in your carotid sinus and aorta, that stimulates sympathetic activity and then the increase of renin release. And in the atria and the ventricles, then you have those sensors cause the increased release of natriuretic peptides. So AMP from the atria and BMP from the ventricles. Angiotensin 2 and noradrenaline are vasoconstrictors. Aldosterone, angiotensin 2, and noradrenaline promote sodium reabsorption, and the natriuretic peptides are vasodilators and promote sodium excretion. So when you have volume expansion, that causes the natriuretic peptides secretion to be increased and the RAS system to be suppressed. So there's a promotion of urinary excretion of sodium. And when there's a volume contraction, then that activates the RAS system and the sympathetic nervous system. And so that promotes sodium retention and vasoconstriction to maintain the extracellular fluid volume. And then just talk about plasma concentration. So the terms plasma osmolality and tonicity are kind of used essentially in a similar way. So the plasma osmolality is the ratio of the plasma solutes and the plasma water. So most of the plasma solutes are sodium salts, and that's why sodium is so important in the regulation of water. And the normal value is 275 to 290. And to work it out, the plasma osmolality, it's 2 times the sodium plus glucose plus the urea. But as you can see, plasma tonicity is what they call the effective plasma osmolality. And that's what's sensed by the osmoreceptors and determines the movement of water across the membranes. And water moves from an area of low tonicity to high tonicity. And the formula there you can see doesn't include the urea. So that's the difference in the calculation, because urea actually can move, it equilibrates itself across the membrane. So that's why it's not an effective molecule in changing the osmolality. So that's why they call it the effective plasma osmolality or tonicity, which is the sodium and the glucose. So the regulation of this, there's osmoreceptors in the hypothalamus, and that senses the change in plasma tonicity. That causes the release of ADH and promotes water reabsorption in the kidneys. So I know this is a strange place to talk about the complications because we haven't gotten to the problems, but I just want to explain why the complications happen that we're so worried about in sodium problems. So the extracellular fluid sodium is a major determinant of the osmolality, as we discussed. So the increase in that causes water to move from the cells into the extracellular fluid, and that causes the intracellular dehydration. And when the extracellular fluid sodium falls, the water will then pass into the cells to equalize the tonicity, and then that causes cell swelling. So this is particularly important in the brain. So when there's cerebral dehydration, the brain will pull away from the meninges and rupture vessels, and that's the complication that we see. And then with the cerebral swelling, it causes edema and compression of the brain against the skull. But the brain is able to alter the ICF osmolytes to try and adjust for these changes in tonicity and to minimize the change of water loss and influx in the cells. And so if the changes that we see with sodium occur over a long time, then when the brain alters its osmolytes, it affects the tonicity. And when we then give fluids to correct that, that's when we can also get into problems, which we'll discuss further. So now I just want to speak about the imbalance. So first we have water imbalances. So the first one is dehydration. And so a nice way to think about this is in terms of if you're losing fluid and so if you're losing water and sodium, or if you're losing water and you're not losing sodium along with the water. So you can have hypotonic fluid loss or isotonic fluid loss. So hypotonic fluid loss is such as diabetes insipidus or osmotic diuresis, like in diabetes mellitus, excessive sweating, which can happen in fever or if you're exercising in a very hot climate and you're losing a lot of water, in hyperventilation or assisted ventilation with unhumidified air, and importantly, in the cessation of water intake. So for our patients in pediatrics, they aren't able to get water on their own. They rely on other people and us and their parents to get them water. So even though they may have an intact thirst response, their mobility and ability to act on that is reduced. And so that's why infants, as well as elderly patients or unconscious patients, may not be able to get the water that they need in order to accommodate for their losses. So in this case, water is lost in excess of sodium from the extracellular fluid. So the extracellular fluid sodium increases, and that was what causes the water to move into the ECF from the cells. So there's increased plasma tonicity, and so you have ADH release and a thirst response. But like we said, if you can't act on your thirst response, then you can't adequately protect yourself. And the urine becomes concentrated, and the movement of water from the ICF to the ECF minimizes the depletion of blood volume. So the patients may not appear to be as hypervolemic as you may think then, because they're replacing it with the intracellular fluid. But when the blood volume does eventually become depleted, you'll get renal hypoperfusion and you'll get renin release, the activation of the RAS system, and aldosterone will cause sodium uptake in the distal tubules, and then you'll get a low urine sodium. So our treatment for hypotonic fluid loss is to use fluids with a low sodium content. So 5% dextrose, 0.45% saline. And like we said, so that rapid correction can be very detrimental because of the osmolytes that I discussed earlier. So you can get iatrogenic cerebral edema if you correct it too quickly. So we want to go slowly with the correction of the fluid replacement. So now to talk about isotonic fluid loss. So this occurs in hemorrhages, burns, GIT losses like diarrhea, vomiting, and fistulas, renal losses that can be from diuretics or polyuric recovery after acute renal failure, Addison's disease, or then ECF fluid going into the body spaces like ascites or hematomas. So now there's no immediate change in the plasma sodium. So there's no movement of the fluid between the compartments. So you're just losing fluid from your extracellular fluid. So your circulatory collapse is more pronounced. And so this causes a fall in renal perfusion and activates the RAS system. So now we again have the low urine sodium because we're causing sodium reabsorption. But there's no change in the plasma tonicity. So ADH secretion only occurs when the blood volume is very, very depleted, and then it can lead to hyponatremia. So now we want to rapidly replace the ECF deficit with 0.9% saline. So you just fluid resuscitating your patient until you've got a hemodynamically stable patient with normal urine output. And there isn't a danger of cerebral edema with this because we're losing equal amounts from both of our compartments. we're not, I mean, because we're not changing the tonicity between our compartments. So this is just comparing the two types. So hypertonic and isotonic. So like you can see the plasma sodium is high in hypertonic dehydration and low and normal or low in isotonic. The hematocrit is high in hypertonic and very high in isotonic because you've got that profound fluid loss from your ECF. And then hypotonic, your ECF volume is low and very low in isotonic. Then your urea is high, but much higher in the isotonic. Your urine output is low. And then your thirst, so you have thirst early on in your hypotonic losses and later in your isotonic because of that tonicity changes. And then with tachycardia, like we said, in your hypotonic fluid loss, you're replacing your ECF that's lost with your ICF. So that's why you don't get tachycardia and hypertension until late. Whereas in isotonic fluid loss, you get it early on. And your fluid replacement, you need to be really cautious with hypertonic, and isotonic, we want to rehydrate them rapidly. Now I want to talk about overhydration. So you get pure, again, it's the same, pure water overload or isotonic water overload. So water and sodium being accumulated. So pure water overload, you get water intoxication from excess intake, but it's very rare because usually our kidneys can accommodate for that. We can excrete large volumes of water. So if your kidneys are working, even if you drink and drink and drink and drink, it really takes a lot for it to actually have an effect. Because your plasma tonicity only has to slightly decrease for ADH secretion to stop, and then your renal function will adjust for that. So usually the causes of water intake in excess and of the kidney's abilities to excrete it. So like psychogenic polydipsia or psychotic patients or something like that, because most of us just won't be able to keep up with the amount that our kidneys will be able to excrete. And then water intake in patients with salt-losing renal disease or diuretics that then impair your tubular salt reabsorption. And then the other major cause is SIADH. So causes of SIADH, which is the inappropriate release of ADH. So the one is intracranial pathology, because then there's a direct stimulation of the hypothalamus and the ADH release. Pulmonary pathology also causes SIADH because the volume receptors in the pulmonary bed falsely report a message of vascular depletion to the hypothalamus, and that stimulates the ADH. You can also have ectopic production of ADH, such as tumors, particularly bronchial carcinomas, and then cortisol deficiency, because then you have an unopposed ADH action. And then pain can also stimulate ADH release, as well as drugs, antidepressants, narcotics, carbamazepine, sulfonylureas, oxytocin, and vincristine. So all of those things. So there's always so many things that can cause SIADH, and a lot of these things are things we see very frequently that our patients often have. So it's important to think about. So the retained water in this is shared between the ECF and the ICF. So the hyponatremia can lead to cerebral edema and decreased level of consciousness. And the more rapid the onset, the more severe the cerebral edema. And the urine will be inappropriately concentrated despite the low plasma osmolality and the high urinary sodium. So yeah, because of this inappropriate release of ADH. So the treatment, usually restricting fluid intake to about 60% is enough in most cases to adjust the sodium. And IV hypertonic saline or mannitol can be used to remove the intracellular water if the patients are symptomatic, but usually it's not necessary. The overhydration can then lead to cerebral dehydration if it's long-standing and if the brain has adjusted the concentration of the osmolytes, and so that can lead to central pontine myelinosis. So that's the big caution. So that's why usually we fluid restrict and see how it goes with that. And now we have isotonic fluid overload. So you get the accumulation of water with equivalent retention of sodium, and then the ECF bears the brunt of the fluid overload because there's not the osmotic force to drive the fluid into the cells, so it stays in the ECF. So that causes hypertension, peripheral and or pulmonary edema, but doesn't cause neurological manifestations because you don't have the changes of the tonicity. And so that can be caused iatrogenically by administration of isotonic fluids, especially if there's impaired renal function or in hyperaldosteronism. So now we're going to move on to sodium imbalances. So hyponatremia is a serum sodium below 135, and it's due to the oral or IV intake of water that can't be completely excreted, as we've said. And if it's caused by a massive water intake, it will rapidly resolve when the water intake stops. So that's, as we said before, our kidneys are able to get rid of excess water if they are still fully functioning. If there's persistent hyponatremia, then that's caused by impaired water excretion. So the inability to suppress the release of ADH, like we said in SIADH, with those causes, and if there's a reduced effective arterial blood volume, so from vomiting, diarrhea, diuretics, heart failure, and cirrhosis. So the clinical features, the severity of sodium deficit and the speed that it occurs affects the symptoms that you see. So if it's gradual or if it's just a slight change, then the decrease, slight decrease, then patients are largely symptomatic, or they can have mild symptoms like nausea, some vomiting. It can lead to a headache. They could be a bit lethargic. But when you have a severe hyponatremia, or if it happens very quickly, and when your sodium drops to less than 120, that can lead to seizures and comas. And you get hyperexcitability, so you get muscle twitching, irritability, and then the seizures. And the cerebral edema then may progress to pontine coning and can lead to death, which is why it's so important for us to know about. So if the patients are hypovolemic, like we said before, you want to resuscitate them with 0.9% saline. And then if you have a symptomatic patient with hyponatremia, like they're in a coma or they're fitting, then you want to correct it quickly. So then you can give 3%, so hypertonic saline, 3% sodium chloride, 3 to 5 mils per kg over 10 to 15 minutes. And then the goal is to correct it, the sodium to about 120. Then you can go very slowly after that. But the initial goal is to correct it to about 120. And so that's why that formula uses 120 minus the measured sodium times the body weight times 0.6 to get your sodium deficit. And then you can correct that. You can carry on correcting that with your 3% saline, or you can correct it slower with different concentrations of saline. But we want to increase it by about 1 to 2 millimoles per liter per hour after reaching 120. And then if they're asymptomatic, you obviously want to do it much slower and it's less of a concern. You do want to correct it and make sure it's improving, but it doesn't have to be so fast. And then if it's a chronic change in sodium, then you want to increase it by no more than 0.5 millimoles per liter per hour. So you want to go really slowly if it's chronic, because we have those changes in the osmolytes. And so we want to really give the brain time to adjust the concentrations. So if excessively rapid rise, it can then lead to osmotic demyelination. If the patients are hypervolemic, then you need to just treat the underlying cause. So if they have hypervolemic hyponatremia, you want to treat that cause. So you can give diuretics and fluid restriction. And unless with those changes, unless there's ongoing loss of your serum sodium, if it continues to fall, then you may need hypertonic saline, but usually it's not going to help. Then going on to hypernatremia, which is a serum sodium of more than 145. So this is when you have the failure to replace your water losses due to impaired thirst or lack of access to water, as we spoke about before. So in our pediatric patients, this is very important, and we see it fairly often. So it can be due to an excess sodium, so such as excess volumes of saline that could be used, or if patients are fed with incorrectly mixed rehydration solutions or incorrectly mixed formulas, then we see it frequently. And it could also be if there's an excess administration of sodium bicarb in a resus, that can also increase your levels. Or if we have a water deficit in excess of your sodium deficit, so like the ones I mentioned before, if there's diabetes insipidus, diabetes mellitus, sweating, diarrhea, dehydration, or insensible losses with a lack of thirst. And so here again, you get your CNS dysfunction, irritability, restlessness, weakness, vomiting, high-pitched cry, tachypnea in small babies can also be a sign. And then the severity of your initial symptoms is not actually predictive of the residual neurological impairment that you can have in these patients. So the management of hyponatremia, you want intracellular rehydration. So again, you want to fluid resusc with isotonic crystalloids, and then afterwards, you want to try and use hypotonic fluids to reduce your serum sodium slowly. So here we want to actually go 0.5 millimoles per liter per hour. So really quite slowly, and should be replaced over 48 to 72 hours. And the rapid reduction here can cause cerebral edema, subdural hemorrhage, seizures, and long-term neurological morbidity and mortality. So that's what we're worried about. But so it is concerning the complications you can have with correcting sodium abnormalities quickly, but you also do still need to correct it. So if it's low or if it's high and it's causing problems, there's also a danger to leaving a patient very hyponatremic or hyponatremic and not correcting it. So then just the take-home messages, the importance of sodium in regulating ECF volume we've spoken about, and the balance relies on an intact thirst mechanism and good renal function. And the changes can have significant CNS consequences due to the brain cells volume changes in response to the tonicity. So very careful monitoring and correction is important to prevent morbidity and mortality in these cases.